Good morning, everyone. And Alan, thank you very much. I want to echo Alan's comments and thank all of you guys again for being here at this incredibly multidisciplinary meeting. Over the next 15 minutes, I'm just going to give a brief sort of overview of the scope of this workshop, what to expect over the next couple of days, what we'll cover, as well as, because we have a range of different backgrounds from some brief, sort of a brief primer about hearing and healthy aging from this context. Starting with some very basic epidemiology, if we look across a lifespan that's based on data from the United States, audiometric data, and we use a definition of hearing impairment defined by the World Health Organization, basically when hearing impairment becomes clinically significant. What we see is that the prevalence of hearing impairment basically doubles with every age decade, right? And this is remarkable, right? Because this means by the time we get to be about 70 and above, that nearly 2 of every 3 Americans has a clinically meaningful hearing impairment, right? At the same time, if we look at one of the most basic stepping stones of hearing loss, just simply using a hearing, so based on the same sort of national data set, we see the rate of hearing aid use is phenomenally low, right? And I'll tell you, this rate of hearing aid use hasn't changed in decades in the United States or across the world, right? And broadly, what we see is that the rate of actual hearing aid use among people with a hearing impairment is about 15% in the States. And I think there's a very natural reason to think then, well, it's so low in the States because hearing aids are rarely covered by any type of insurance or not covered by Medicare, right? And because that's so low. But it's not quite true, though, right? Because we go to other countries, for instance, Western Europe and the United Kingdom, where hearing aids are fully covered by national health insurance, their rates of hearing aid use are, in fact, just a little bit higher, but not substantially higher. So I think what this gets at more than anything else, that while cost is critically important, cost is not the only issue, right? Namely, if you look at broadly at some of the most basic public health questions pertaining to hearing loss in older adults, these questions are unanswered or just beginning to be answered now. And these are the questions that are really going to drive this workshop over the next couple of days. We're going to discuss what's been done for each of these and what we need to do going forward, right? I mean, so if you look at the first question, pretty basic. I mean, what are the consequences of hearing loss for older adults? I mean, is it just the issue of communication, or is it issues of quality of life, or even possibly domains beyond quality of life, right? Second question then, given this possible impact, I mean, what are our options for even addressing and treating hearing loss in the individual, right? And what is the impact of those treatments? And finally, the third question, probably the most important, is that given that 2 out of every 3 adults over 70 has a meaningful hearing impairment, how do we even go about addressing that as a society, right? So you realize now that because these questions are just beginning to be answered and haven't really been focused on from this multidisciplinary context before, is that there's an amazing paradox in society now, which probably many of you are familiar with, right? So I'll go over this a little later, but this basically shows a mild hearing loss, right? And if I told you that this belongs to John and he's a 12-year-old boy, I can guarantee you across insurance companies, physicians, patients, providers, they'll all agree this hearing impairment has to be addressed because it can impact how well this child can communicate with his friends and family members, how he can hear his teacher, right? Yet the amazing thing about this is while this hearing impairment is critically important, if all of a sudden we said John is now 72 years old, right? The same hearing impairment, the same functional impact on communication, and all of a sudden I can tell you now, usually this hearing impairment would be met with a shrug, saying, well, you know, you have a mild hearing loss, but so does everyone else your age, right? So there's a fundamental paradox there, right? The same functional impact on communication, same hearing loss, critically important for one member of society, but not so important for another, right? And I think what this really gets at, again, is these questions have never really been approached yet conceptually from a multidisciplinary point of view that we're going to do over the next couple of days, right? And importantly, one of the first questions I'll be addressed on early in this workshop is really the first one, the consequence of hearing loss. And particularly where we're going to start with here now is really from this perspective, right? This concept of healthy aging, which I think is one of those things all of us in this room are implicitly familiar with. We sort of know what it is. And a lot of times I think healthy age is one of those things you know it when you see it, right? So the top right, this is Gladys Burrell. She was 92 years old when she finished a Honolulu marathon, right? So clearly a very vibrant, dynamic picture of healthy aging, right? In contrast, an older man with mobility impairments in a wheelchair in a nursing home. Clearly, what many of us consider probably not to be the ideal picture of healthy aging, right? In the top left, a grandmother interacting with her granddaughter on a daily basis, clearly remaining cognitively, socially engaged with her family, right? Clearly a very dynamic picture of healthy aging. And in contrast, an older woman in a nursing home with early dementia, clearly probably what many of us would probably not expect of healthy aging, right? So importantly, what's going to be reviewed in the first portion of this workshop is really this link possibly between hearing and these domains which characterize healthy aging, sort of cognitive and physical functioning. Now, to provide some brief background about this, I think intuitively, a lot of us, when we think about this issue, will always want to say, well, of course, they're related, but it's through some type of common pathologic process, namely aging or maybe some of the cardiovascular risk factors, right? But clearly, from a public health standpoint, that's all that links these two. I mean, who cares, right? Because it implies no matter what we do from a public health standpoint to address, treat, hopefully even prevent hearing impairment, we're not going to make a difference on these downstream outcomes, right? So what I'm going to go over now, just briefly over the next few slides, is begin thinking about how could hearing impairment be constantly contribute in some way, mechanistically, in some way, shape, or form to cognitive physical functioning. And to do this, though, I'll need to give some basic, just three very, very basic slides here about just basic hearing and auditory physiology, just to make sure all of us in the room are on the same page as we begin this workshop. And the first principle is pretty basic, and it's that hearing, when we talk about hearing, hearing depends on two incredibly basic processes. It depends on peripheral transduction of sound, the cochlea, and then central processing or decoding of sound, the brain. So in other words, what I mean by that, if you look at the top left, this is a speech spectrogram of a complex sound. All speech is complex, right? So it's composed of different frequencies. Each different frequency has different intensities, all progress in real time, right? So the whole job of the cochlea, right, the whole job of the cochlea right here in the middle is to take in that incredibly complex set of sound vibrations and to transduce it with accurate fidelity into a signal that then goes to the brain for decoding, right? So for the engineers in this room, this is fundamentally a process of encoding peripherally and decoding centrally, right? So when we talk about hearing then, we can imagine you can measure hearing at multiple different levels, right? We have sort of more peripheral measures of hearing that characterize how well the cochlea does, things like otoacoustic emissions, things called pure tone audiometry, sort of a hearing test I'll show you in a bit, as well as more central measures which get much more central functioning. For example, just someone's overall communicative abilities in real life, or even speech and noise tests, where while those central measures, they depend clearly on the peripheral inputs or bottom-up processing, they also automatically depend, sometimes even more so, on sort of top-down cognitive processing of that signal, right? So you can measure at multiple different levels, right? Importantly then, when we think about basic bread and butter age-related hearing loss, a lot of times what we're talking about then is usually peripheral impairments in the cochlea. So the cochlea is comprised of many cells which are all post-mitotic, meaning they can't regenerate. So over time, there's susceptible to damage from aging, noise, medicines, et cetera, right? So when we talk about measuring hearing, a lot of times what we're talking about is measuring the peripheral cochlear function. How well can the cochlea take in and encode a sound and send to the brain, right? And the way we do this traditionally through a lot of epidemiologic and clinical work as well is, you'll be presented with different frequencies of different sounds. So 250 is a low-pitch sound. 8,000 is a very high-pitched sound. And at each of these different sounds, we'll measure how loud it has to be for the individual to hear it. And these are these different intensities. 0 decibels will be very, very soft. 40 is roughly about a whisper, 60 is conversational voice, right? And typically, just for us to simplify things, we typically say when you can hear sounds that are less than about 25, it's considered normal hearing. Then 25 to 40 is a mild loss, then a moderate loss, et cetera, right? And classically just sort of simplifies even more. What's often done clinically as well as from a research perspective is people just sort of summarize someone's pure tone average, their hearing ability specifically in this range of frequencies which are critical for speech, right? So the higher the number is, the worse your hearing losses per se. The lower the number, the better the hearing per se. You hear very, very soft sounds, right? All right, so with those basic three principles out of the way, I think we can possibly start exploring now how hearing impairment can contribute to these domains of healthy aging. Because remember what I said before is that when you have hearing loss, it implies that there are impairments in the cochlea over time. And what this leads to is not only issues of decreased hearing sensitivity, you can't hear soft sounds, but probably more importantly, a very poor frequency and temporal resolution. So instead of the cochlea being able to precisely and crisply encode this very, very complicated sound, it sends a very garbled signal to the brain, right? And this is why classically, for any of us who have friends, relatives, parents who have hearing impairment, what they'll say to us all the time, it's not that I can't hear you, it's that I can't understand you, right? It sounds like you're mumbling at me all the time, but that's what hearing loss does. And what this has been described as in the past is very much a process of effortful listening, right? That you can still hear, you can still make it out, but you got to concentrate that much harder to make out what's being said, right? So one way then that's been hypothesized through which hearing impairment could contribute to cognitive physical functioning is the idea of cognitive load, right? Does a brain constantly have to rededicate attentional and cognitive resources decoding a very garbled signal, and has then come at the expense then of other systems, right? So I'll tell you that's one idea. Another idea has been hypothesized now is just that hearing impairment, sort of similar mechanisms now, can lead to direct changes in brain structure that can lead to cascading consequences on function, right? Namely, if you have a very, very impaired, garbled auditory, very impoverished auditory signal sending from the ear, does that actually precipitate structural and functional changes in the brain, right? And finally, probably one of the most intuitive ideas to which hearing impairment can contribute to cognitive and physical functional problems is this basic idea that hearing impairment in some way, shape, or form can contribute to social isolation, right? And for many, many decades now, we've long known that social isolation is arguably one of the main drivers of morbidity and mortality in older adults. So with that in mind, though, I think one of the key questions which will next be addressed in this workshop then is, well, given this possible impact, how do we even go about addressing hearing impairment at individual level, right? And what are the impact of those treatments? And specifically, we'll cover several topics. We'll look at specifically how is hearing impairment even sort of assessed in terms of hearing needs assessments, the rehabilitative strategies for addressing hearing impairment in the individual. We'll talk about the hearing healthcare workforce, who is actually out there to address hearing impairment for the individual. And finally, we'll actually have extended discussion of actual technologies that are available, hearing aids versus something called personal sound amplification products, what are the difference between the two and how they can be used to address hearing impairment at the technical level, as well as the role of hearing loop system, hearing system devices. And this is critical. I mean, the hearing loop systems are, for example, there's one in this room right now, a little wire that goes around the room. So if you're in the back of the room and the acoustics in this room are pretty good, but if you have bad acoustics, if you had a hearing aid, you push the T-coil in your hearing aid, and anything that I'm saying over this microphone goes straight to your hearing aid, which can make all the difference in these settings, right? So we'll discuss these technologies as well. Finally, probably the third most important question we'll begin discussing too is this last question of, well, how can age-related hearing loss be effectively addressed in the community? Namely, if two-thirds all older adults have a meaningful hearing impairment, how do we even begin confronting that as a society, assuming that we want to address it, right? And there'll be several topics that we're going to discuss here. Probably one of the most important ones is this thought process of how do we begin understanding and approaching hearing loss in the context of healthy aging. What I mean by this is, probably for many of us, hearing is just one of those processes that's very much a usual process of aging, right? But if we begin viewing it from the context of healthy aging, it becomes that much more important, right? Otherwise it's just sort of seen as just a relatively just a normal part of aging, right? And I think what we'll talk about is specifically collaborative strategies for research, education, awareness that need to go forward, bringing in all the different stakeholders who are now in this room. The second big thing we'll discuss is actually delivery models of hearing healthcare, right? And also insurance coverage. You know, how do we go about delivering more accessible models of care, given that two-thirds of all older adults have a hearing impairment? And what can we do to bring about some type of third-party reimbursement for these services, right? And finally, the third question we'll discuss is sort of actual innovations in hearing technologies. What can be done going forward to actually develop more affordable, accessible, innovative technologies, and also the role of open wireless standards. You know, for example, why can't a simple iPhone right now, why can't that signal go straight to a hearing aid? It basically can't, right? So we'll discuss those issues as well, right? So this is just sort of a summary slide. I think as we begin this workshop, many of us would probably agree, I think, that overall, if we look generally at the status of hearing loss, age-related hearing loss society right now, that I think for a lot of people it's generally viewed as relatively inconsequential. It's a usual process of aging, hence it's just relatively inconsequential, right? I think it's very poorly understood, not only among patients and consumers, but also among the research community and providers. And I think it's incredibly stigmatized, right? Likely, I think also probably many of us would agree too that many of the current technologies and the actual models of care aren't meeting the needs of many, many individuals in society, right? And I think this overall perception probably hasn't changed now in probably 50, 60, 70 years, right? But I think more so than ever, I think a lot of us recognize now there are certain trends in society right now that are going to force a change over the next 5, 10, 15, 25 years. And one big factor is this one that we'll discuss early in the workshop, is our increasing insights into the fact that optimal hearing is likely critical for many, many aspects of functioning and healthy aging, right? Along the same lines then is that right now we're clearly facing the tip of an iceberg in terms of an aging society with baby boomers, right? And baby boomers are fundamentally different previous generations, I would say, in demanding a certain different level of what they expect from later life in the third age, right? Where the idea that hearing impairment is important now just isn't compatible with the idea that hearing loss inconsequential should be ignored, right? And finally, I think many of us know this already, but there's been incredibly rapid progress just in the last 5, 6, 7 years with the pace of technologies in terms of wireless connectivity and actual technology out there for hearing and other types of systems, right? So I think all of us probably recognize, I think going forward, we had a crystal ball. I think in the next 20, 30, 40 years, probably what many of us would expect this will probably come out of eventually with these trends, right? That sounds almost self-evident that we'll approach hearing loss, understand the context of healthy aging, where Optimal hearing will be understood to be critical for daily functioning. Almost sounds self-evident, right? That there'll be more expanded, transparent options for hearing healthcare. And finally, there'll be some degree of some type of third-party reimbursement. Now, I think regardless of this workshop, this would go ahead eventually. But I would argue it would probably take 10, 20, maybe 30, 40 years. I think what all of us hope as we begin this two-day workshop is this workshop will begin catalyzing this change quite simply, right? So rather than taking 20, 30, 40 years, whether we can accelerate this process over the next 5 to 10 years to bring this about, right? So I will finish up there, and I want to introduce our first speaker. So Catherine Bouton is someone I consider to be a close friend of mine, who is a former editor of the New York Times, and who has dealt with sort of age-related hearing loss over the last 20, 30 years of her life. And she recently wrote a memoir about her experiences sort of dealing with age-related hearing loss with her life in the journalism industry, and she'll present her experiences. So I'll ask Catherine to come up now.
Thanks. Wait, I need you to show me how to use the